Maternal screening is a grouping of prenatal tests incorporating ultrasound measurements and laboratory data obtained from maternal serum. The goal of screening is to identify women at high risk of carrying an affected fetus by either an aneuploidy, such as trisomy 21, commonly known as Down syndrome, trisomy 18, also known as Edwards syndrome, and trisomy 13, also known as Patau syndrome, as well as neural tube defects such as spina bifida. The purpose of screening for these conditions is to target invasive diagnostic testing only to those pregnancies that are calculated to be at a high risk. While maternal screening strategies such as the second trimester quad screen are also used for screening for open neural tube defects, the focus of this presentation will be screening for the chromosomal aneuploidies. And to begin, I will briefly discuss trisomies 21, 18, and 13. Individuals with Down syndrome carry an extra copy of chromosome 21 and often display characteristic physical traits such as upward slanting eyes, a broad, flat nose, and macroglossia, or a large tongue. Down syndrome individuals also display mild to moderate developmental delay, as well as an increased incidence of thyroid disease, cardiovascular disease, megakaryoblast leukemia, and acute lymphoblastic leukemia. It is commonly appreciated that there is a maternal age-related increase in the incidence of Down syndrome. The incidence of Down syndrome live birth is approximately 1 in 2,000 at a maternal age of 20. This risk increases to 1 in 350 live births at a maternal age of 35 and continues to increase beyond that age. The incidence of Down syndrome at mid-gestation is slightly higher at 1 in 270. However, some pregnancies will, of course, end prematurely, resulting in a slightly lower incidence at birth. Some individuals are at greater risk of having an affected pregnancy, such as those with a family history of Down syndrome, or if they have had a previously affected pregnancy. It is important to recall that all women are at a risk of carrying a child with Down syndrome, and the overall incidence is approximately 1 in 730 live births. The second most common autosomal aneuploidy for which screening is also performed is trisomy 18 or Edwards syndrome. The effect of this trisomy is more severe for the fetus than that of trisomy 21. The affected fetus and neonate will have multiple defects, including atrioventricular septal defects, horseshoe kidney, omphalocele, esophageal atresia, and severe developmental delay. Trisomy 18 is the second most common autosomal trisomy with an incidence of 1 in 5,500 live births. As with trisomy 21, the mid-gestation incidence is much higher, but many affected fetuses die in utero. Similar to trisomy 21, there is also an age-related increase in the incidence of trisomy 18 with advancing maternal age. Of those affected fetuses that do survive to deliver, approximately half will not survive the first week of life, and 90% will die within their first year. The last autosomal trisomy that we will discuss is trisomy 13, or Patau syndrome. As with trisomy 21 and trisomy 18, there is an age-associated risk of having an affected pregnancy. The prevalence of trisomy 13 is less than both trisomy 21 and 18, with approximately 1 in 10,000 live births. Trisomy 13 affected individuals display a number of defects, including, but not limited to, holoprosencephaly, a sloping forehead, severe eye malformations, deafness, cleft lip and or palate, polydactyly, and congenital heart defects. Approximately 80% of affected neonates do not survive past 1 month of age, and only 5% survive to 6 months. For those that do survive beyond 1 year of age, they display severe intellectual disability, seizures, and failure to thrive. Prior to beginning our discussion of the different maternal screening options available, we will first discuss how a definitive diagnosis is established. The only conclusive diagnosis of the aneuploidies comes from obtaining an adequate amount of fetal material to perform fluorescent in situ hybridization, or FISH analysis, and or a karyotype spread to determine if an extra copy of one of the chromosomes is present. While either a karyotype or FISH analysis will establish a definitive diagnosis, obtaining sufficient fetal material for analysis is not without risk. Chorionic villus sampling, and amniocentesis have a small but quantifiable risk of inducing pregnancy loss. For CVS, the risk is on the order of 1 loss per 100 procedures, while amniocentesis carries a lower risk of approximately 3 pregnancy losses per 1,000 procedures. As there is an unavoidable risk of pregnancy loss associated with the diagnostic procedures, and to adequately target diagnostic testing to those pregnancies at high risk of carrying an aneuploid fetus, screening tests have been developed. Currently, patients are screened via a combination of first trimester ultrasound and maternal serum markers alone, or in combination with second trimester maternal serum markers to assess risk. The choice of which screening strategy to choose will depend on the time of patient presentation. For example, if the patient presents early in gestation, the first trimester screen will be carried out. But if the patient does not present until the second trimester, the screening test used would be the quad screen. As you can see, there is more than one screening strategy, and the decision on which tests are available will depend on the time of maternal presentation for prenatal care. The first trimester screen is a combination of ultrasound measurement and maternal serum markers. The second trimester screen is solely an assessment of risk based on the concentration of 4 maternal serum markers. This screen is popularly called the quad screen. However, it is also known by many other common names. There are also a few options that combine the risk calculation for the first and second trimester screens, including an integrated screen, serum integrated screen, and sequential screening. The data obtained by any of these screening choices, which we will be discussing shortly, are reported as a multiple of median. The multiple of median is used for these screening programs as the ultrasound and serum marker values vary significantly throughout gestation. By converting the marker concentrations into a multiple of median, the reporting of values is standardized for gestational age, race, and for differences in measurement platforms. Establishing a database for multiple of medians requires a large number of well-characterized singleton pregnancies that are known to be unaffected by chromosomal aneuploidy. The use of the multiple of median does not obviate the need for the establishment of a reference range by race and by platform for each week of gestation, but it does simplify the reporting of values. Converting a serum marker value into a multiple of median is simply done by dividing the obtained value by the gestational age specific median value for the analyte to be reported. The calculated multiple of median value can then be used to determine the likelihood ratio for carrying an affected fetus. In this example, the HCG multiple of median was determined to be 2.0. This value is plotted on a distribution of HCG values in normal and Down syndrome affected pregnancies. As you can see in this simplified example, an HCG value of 2.0 multiple of median is equal to a likelihood ratio of 2 of carrying a Down syndrome fetus versus an unaffected fetus. This likelihood ratio is then multiplied by the patient's age-related risk to determine the risk of carrying an affected fetus. In this highly simplified example, we are only considering one marker. However, calculating the overall risk of carrying a Down syndrome or trisomy 18 fetus involves sophisticated formulas incorporating nuchal translucency, if measured, the other biochemical markers, as well as whether the patient has type 1 diabetes mellitus, their body mass, and smoking status to generate an overall relative risk. Now that we have discussed how the measurements are normalized to multiples of median, we can discuss the various screening options that are available. The first trimester screen is ideally performed between the 11th and 13th weeks of gestation, although it may be performed as early as the 10th week and as late as the 14th week. This screen is a combination of ultrasound measurement of nuchal translucency, which is a fluid-filled space at the back of the fetus's neck, as can be observed in the photograph at right, pregnancy-associated plasma protein A, and the free beta chain of HCG. In the first trimester screen, trisomy 21 fetuses will typically display an elevation in both the nuchal translucency measurement and the HCG beta chain concentration in respect to unaffected pregnancies, while the PAP-A concentration will be decreased. Trisomy 18 affected pregnancies will also display an increase in nuchal translucency, and all serum marker concentrations are typically lower than in unaffected pregnancies, with PAP-A and HCG significantly lower than unaffected. Trisomy 13 affected pregnancies will also display an increased nuchal translucency and moderately to severely decreased PAP-A multiple of median and decreased HCG. A screen-positive result for the first trimester screen is a calculated risk of 1 in 270 for Down syndrome or 1 in 100 for trisomy 18. At these cutoffs, the first trimester screen reportedly will detect between 79 and 92% of Down syndrome-affected pregnancies at a false detection rate of 5%, depending on the publication cited. At a false positive rate of 1%, the first trimester screen will detect 89% of trisomy 18 affected pregnancies. The first trimester screen will also detect 90% of trisomy 13 affected pregnancies at a false positive rate of 0.5%. While these values are from published peer-reviewed studies, individual laboratories may report varying detection and false positive rates. The first trimester screen also offers the patient the advantage of increased privacy as the screening takes place early in pregnancy, and it also offers a wider window in which diagnostic testing can be done to either rule in or rule out the diagnosis of a chromosomal aneuploidy. The first trimester screen does, however, have the disadvantage that it cannot screen for neural tube defects, and a return visit and blood draw would be required to screen for open neural tube defects. Another option, the second trimester screen, commonly known as the quad screen, is a combination of 4 maternal serum markers: alpha-fetoprotein, total HCG, unesterified S-triol, and inhibin A. This screen is performed between 15 and 22 weeks of gestation and is designed to screen for both the chromosomal aneuploidies and neural tube defects. As you can see in this table, the detection rate for Down syndrome in the second trimester quad screen is similar to the first trimester combined screen at the same false positive detection rate. As for detection of trisomy 18 affected pregnancies, the two cannot be directly compared as their false positive rates differ, and the quad screen does not detect trisomy 13 affected pregnancies. Since this screen incorporates the measurement of alpha-fetoprotein, it may also be used to screen for open neural tube defects. A multiple of median greater than 2.0 or 2.5, depending on the laboratory and prevalence of disease in the population being tested, is a screen-positive result. This screen will detect approximately 85% of open neural tube defects at a false positive rate between 2 and 5%, depending on the testing laboratory and literature source. In addition to the 2 separate first and second trimester screening options, there is also the option of one of 3 cross-trimester screens to assess risk. The first we will discuss is the integrated screen, which is a combined risk assessment of the first trimester nuchal translucency measurement and PAP-A concentration and the second trimester quad screen components. In the integrated screen, all of these values are used to calculate an overall risk of carrying a trisomy 21 or trisomy 18 fetus. In the integrated screen, there is no disclosure of the patient's risk after the first trimester screen. The serum integrated screen is identical to the full integrated screen with the exception of the nuchal translucency measurement. The nuchal translucency measurement must be performed by a certified ultrasonographer. In some communities, access to a certified ultrasonographer may not be possible, and at times the nuchal translucency measurement may not be obtainable due to fetal position, maternal habitus, and possible lack of insurance coverage. Despite the lack of the nuchal translucency measurement, the first trimester PAP-A concentration can still be incorporated into the calculation with the second trimester serum markers. The third cross-trimester screening option is the sequential screen. As with the integrated screen, the sequential screen incorporates both the nuchal translucency measurement as well as serum markers from the first and second trimester to calculate risk. The sequential screen does, however, differ from the integrated screen by disclosing the calculated risk result to the patient if the calculated risk is greater than or equal to a predetermined cutoff in the range of 1 to 50 to 1 to 40. If the risk of carrying a Down syndrome fetus is less than the cutoff, the results typically are not revealed to the patient and the values are combined with the risk assessment from the second trimester. If you compare the detection rate of either the full integrated screen and sequential screens, you'll note that either of these two options will result in the highest detection rate and lowest false positive rate for Down syndrome of any of the screening protocols. In literature sources, the serum sequential screen, which does not include the nuchal translucency measurement, does not perform to the same level as the full integrated screen. In regard to the detection of trisomy 18, the data for this condition is not as well characterized in literature, but the detection rate in the serum integrated screen is 92%. As the nuchal translucency measurement is also increased in trisomy 18, it is likely that the use of the nuchal translucency measurement would increase the detection rate, but those publications are lacking. Following a screen positive result from any of the screening programs, the first step should be to verify gestational age to avoid an inaccurate determination of relative risk. Should the gestational age be accurate, genetic counseling and diagnostic testing should be offered to the patient, and this follow-up testing may include the use of a high-resolution ultrasound. For the first, second, and integrated screens, a screen-positive result for trisomy 21 is a calculated risk of greater than or equal to 1 in 270, the same as the age-based risk of a 35-year-old woman. For trisomy 18, the threshold for offering diagnostic testing is a calculated risk of 1 in 100. As mentioned, the sequential screen is slightly different due to the two-stage testing. According to the American College of Obstetricians and Gynecologists, all women, regardless of age, should be educated on screening options and be offered both screening and diagnostic testing. Which testing is pursued will depend on the time of patient presentation for prenatal care. It is important to recall that these screening programs are not diagnostic tests. As the overall prevalence of trisomy 21 and trisomy 18 is fairly low, these screening tests will falsely identify more unaffected pregnancies than affected ones. For instance, if 1,000 individual women are screened at a false positive rate of 5%, 50 patients will receive a high-risk result. That value of 50 in 1,000 is the same as 1 in 20, and the overall Down syndrome prevalence, not taking into consideration maternal age, is 1 in 730. It is also important to recall that screening will not detect all cases of fetal chromosome aneuploidy. Regardless of the screening result, the risk estimate should always be communicated to the patient, as the patient's interpretation of the risk and the choice of whether to proceed to diagnostic testing is important.